I'm Paul Louis Metzger, the director of the Institute for Cultural Engagement, New Wine, New Wineskins. Welcome to another episode of New Wine Tastings, where we are seeking to build relational bridges through Jesus in contemporary culture. And one of the areas we're really interested in at New Wine is faith and science and bridging those domains, an approach where, as my colleague, Dr. Robert Potter, helped us form this years ago with Multnomah University's own approach to faith and science to develop an informed respect between faith and science, and where possible to move toward integration. He and our other science advisor, Dr. Steve Combs at the University of Portland, Dr. Robert Potter, who most recently was at Oregon Health and Science University, worked with theologians and us at the University and Seminary in New Wine to work on integration. And part of that integration involves this theme of medical ethics. And so what we're dealing with today is a personalist approach to medical ethics. Three cardinal questions pertaining to a personalist approach to medical ethics. Dr. Potter, thank you for joining us again at New Wine Tastings. And I always love your array of bow ties. They're phenomenal, and it's a new one for this week, and I love it.
I wear them just so I can remember how to tie them. Okay.
I wish I looked as good in bow ties, and I love bow ties, but I don't look as good in them as you do. So
I tie them so they're not quite regular, so people know that they're tied and not all pre-manufactured noise. That's good. I let them be just a little crooked.
That's good. That's good. Well, as you and I have discussed before, there are various approaches to personalism and personalist approaches to ethics. And you foster a particular personalist approach to medical ethics, and you have various influences that have shaped your own thought. What are some of those personalist influences in philosophy, theology, ethics that you would want to outline for us today, just briefly?
You know, when you just take the word personalist and explore it in the theological world, you stumble immediately into that Boston Seminary School of Theology that was all about personalism. Got started at the beginning of the 20th century and was really very influential for the first 25 to 50 years. But that group of authors, even though I explored them, did not grab me as tightly as others who had begun to approach the human being not with the word person as the core, but the word self. And the responsible self then became one of the code words for understanding what a person was from my perspective. And that's how it was that this famous book entitled The Personal Self of H. Richard Niebuhr became so important to me. However,
was that the responsible self?
The responsible self, excuse me. So, but even before that, there was quite a movement within medicine, even sort of before ethics became sort of a dominant theme, which was late 1980s. Earlier in the 70s and 80s, there was a humanist movement within medicine that said, let's listen to the patient who is a person. Or another way to say it, let's listen to the person who is a patient. And that theme really became much of what caused me to think about going on to a PhD, which I did in sort of mid-professional life rather than the usual technique, of jumping right out of one school into another. I practiced medicine and was teaching as professor of medicine for 15 years or so before I even considered doing my studies at the University of Chicago Divinity School, where I was then, of course, very rapidly induced into a study of self, the human agent, the person, and so on. And I was in touch with a group of theologians and doing theological ethics out of the Yale School. And of course, there's their little competition between Yale and Boston. You know, I think the boys over at Yale, rather than just repeating the word personal and personalist, decided to use the words self, human agent, those words. Yet when you look at their writings, when they use those terms, even when my mentor James Gustafson uses that, oh, excuse me, that word man, in 1981, they understand, you got to give him a little grace there, to talk about the human being. When you look at what they mean by man, agent, self, etc., they're really describing what others described as person. So they're just using the language a little bit differently. And so I always felt like that what I was doing was a very personalist oriented thinking. So, you know, my PhD work is in essentially in psychology, religion, looking at psychology, social sciences, cultural anthropology, that whole business of describing the human being. So the background of my work was always immersed in the notion of what it is that we're dealing with when we're talking about us, ourselves, we persons in the universe. So whether I would be, you know, technically labeled as a personalist or my teachers as personalists is questionable, but I knew them to be focusing down on what you and I now like to call the person. So, you know, it wasn't much of a leap in the language to go from the concept of self and human agent and so on over to the concept person. So I felt all along that I was engaged in doing personalist ethics, developing a notion that I was paying attention to the person. And now especially defining the person by the values by which they felt themselves identified as a person, and the values by which they felt themselves directed and motivated to respond and act in the world. And so for me, the person was the self whose values drove their action. You know, that's sort of a simplified definition of person, a self whose values drive their action. That's why I've given that little cute little distinction of what a human is that the brain is this values driven decisional system, you know, that I've used before. To me, what is at the core of being a person is the value system that they have developed and has been developed in them as they've grown up. Now, in addition to that, I would like to say that those that I was reading and being instructed by at the University of Chicago were very much engaged in the notion that each individual self was not an autonomous, you know, windowless self that was sort of self-contained. No, the self is socially created. The self is a social structure created by interactions, relationships. So if I would choose another word besides values to define the person, it would be the relationships in which they exist, the relationships to which they are most responsive, the relationships to which they're responding when they act. So relationships are right at the core for me of what person is. So when I talk about person, being a personalist, I'm talking about that human being that is guided by their values, that acts out of their relationships, that exists as a social creature, a social creation, by the relationships in which they exist. And, you know, there were multiple famous people that were constantly reminding me of all this. Buber, for instance, you know, the famous Jewish theologian and thinker, you know, personalist to the core, personalist to the core, read his material very early, while even in college, of course. Odd to say so, but Paul Tillich, who's one of those that I read the philosophical theology in quite early, I remember one line. He said, the goal of a person is to be a person in a community of persons. You know, that you know, without his defining what person meant, that to me was the essence of it all. You're a person in a community of persons. That's how you get to be a person, is to be in a community of persons. Then I fell under the trance, particularly starting in 1985 when I was at the University of Chicago in the early parts of my study. I began to read what I call care ethics. Authors Nell Noddings, Carol Gillihan. These were persons who said, let's approach ethics from the point of view of how is a person using their values to come up with their position, their moral position in any one situation. You see, the reason I was doing that was that there was a very strong sense of principle-oriented ethics at the University of Chicago, because we were following a famous author whose name right now escapes me for the moment, who is a principle centered. And that rationality was what was the way you used to come up with an ethics decision, an ethical decision. And you know, that principlist point of view didn't exactly cut out the person. You can't do that, actually, but they didn't focus on the person. And you turned over to care ethics, which, by the way, was pretty much influential in nursing, in the whole instruction of nursing, which, even though I was professor of medicine, I was engaged in instructing nurses all through my professional life and continue doing that. Even now in my retirement, I am teaching ethics in a nursing program here in Portland at Warner Pacific. And that notion of the person as the center of thinking in ethics is just something for which I feel that I have been raised into from a very early part of my thinking about how I went about doing medicine. You have to also remember, I'll throw this as the third piece. The third piece is that I was looking for the relationships between faith and medicine from the very moment I stepped into medical school. And as I continued to read about that, it was always the notion that you look at the whole person who is made in the image of God, that you considered their body and their mind, and let's say something more mysterious about their spirit, but you always see the whole person. And that was what the way I structured my own thinking about doing medicine. So, and encouraged by that with some writings that were beginning to emerge about medicine and spirituality. And so, you know, those influences, I think, kept me in line, Paul, kept me in line so that I never drifted away from the notion that the person is at the center of my thinking when it comes to ethics.
Thank you, Robert. And so just to sum up what I heard just now, you talked about the Boston School, hugely significant. If you look behind my head, you can see Dr. King. He was schooled in that tradition. And he himself is considered by many to be a personalist in his orientation. Rufus Burroughs' work on King gets at that. Rufus Burrough, probably more than anyone else on King in terms of personalism. And you said, you were influenced by the Yale School, down the road, so to speak, from Boston, shall we say, hop, skip, and a jump. And then, as your own professor moved from Yale to Chicago, that's, I think, how you connected the dots there. So all that said, that was a major influence. What happened at University of Chicago, influences there, Niebuhr, who had been at Yale, H. Richard with The Responsible Self, then care ethics, all that occurred there in that context. And then lastly, you just mentioned your own personal drive as a believer moving into medicine to begin with, always accounting for that from day one. Right. We could mention Paul Tournier. My wife loved
I read everything of Paul Tournier in my first year of medical school.
Yeah, and Paul Tournier was a personalist, no question about that. And it's in the titles of his books. And I think there's a lot of overlap between you and Paul Tournier. Yep. My wife Mariko, for her psychology work, loves Paul Tournier. She has all his books, and incredible influence. You mentioned Niebuhr. You mentioned Martin Buber. My own professor, Colin Gunton, I would see in many respects as a personalist. Karl Barth, I think, has personalist trajectories. John Zazoulis, one of my teachers, a personalist. You mentioned last week, Christian Smith, Notre Dame, a scholar who in sociology of religion is saying we need to engage personalism through and through. I think it's important that we just draw attention to this because there are so many diverse forms of personalism. Christian, non-Christian, other faith traditions have personalist thrust. We're looking at yours as it engages medical ethics, and that's what we're going to get into further. But this week, talking about the 3 cardinal questions that have shaped your own approach. And I just have to say to the viewer, I have found Dr. Potter's own engagement of these things extremely helpful to my family and me, as my son is on life support in a coma for a traumatic brain injury that he suffered months ago. And to treat Christopher as he is, as a person. And as one really good nurse at the hospital where he's at said, we're waiting to see how Christopher responds. And regardless of where this nurse is coming from philosophically, to me, as a personalist, as an ethicist, and my wife as well, we took that to heart because we were accounting for Christopher, not a system only, but Christopher and his agency. And like that to me is bound up with personalism as such. And then Dr. Potter helping us navigate questions. And as a Christian, looking at the cup half full, not half empty, and how we engage people. So all that to say, I have found it extremely helpful. As intense and as dense as this conversation may be, it has real practical import. And I won't go into detail, but let me just say it has real practical import. Dr. Potter will share a case study that he's developed before too long in our conversation today. But back to Niebuhr. Whether one would consider H. Richard Niebuhr a personalist, ethicist, his book, The Responsible Self, has left its impact on you. And you've already mentioned that. We didn't get at his key questions that he develops and your third question that you put in between the two. So his first 2 questions, what are those questions? And what is so significant about those 2 questions, not your third question, but those 2 questions, before we get to the third, in your estimation, as you foster a personalist approach to medical ethics?
Well, you got to remember, H. Richard Niebuhr was a good old Missouri boy, born just over near St. Louis, born in the late 1800s, good old German family, comes from the Middle West. And he said in his book, in Ethics, The Responsible Self, there are just 2 questions in ethics. What's going on here? And what's the fitting response to what's going on here? I mean, that's just country boy talk, what's going on here? Yeah. And what he meant by what's going on here is so important to me as a physician. Somebody comes into my care and there's something wrong. What's my question? What's going on here? The first thing I do is make a diagnosis. Figure out what is the situation? Describing the situation, whether it has to do with why has somebody got a fever of 105, you know, and their neck is stiff, well, maybe they got meningitis, who knows? But, you know, or whether it's why is a person coming to me with this question about what they should do with their wayward son, let's say. What is the situation in which the person exists? And coming up with an accurate description of that is the first task of doing ethics, is describing the situation. Now, how much detail you go into is an issue. On the other hand, let's say that I'm called to do an ethics consultation at a hospital, and I don't know quite what the situation is. And I've got 6 people in the room. I've got the nurse, I've got the respiratory therapist, I've got the social worker, I've got the physician, I've got the patient's wife, you know, I've got 5 or 6 people in the room. I want to hear from every one of those people as to how they describe, how they understand, how they interpret the situation. And from all of those angles, those various angles of perspective, I will develop a view of what's going on here. And that's essential. And I think all of us who are dealing with any kind of ethical decision, we need to be pausing long enough to be sure that we understand what's going on here. So often we rush to the judgment of what's going on here and we react. And people are known to sort of have, we say, the gut reaction to what we ought to do here, and without thinking over what's going on here. That's why I want to be very clear that in doing ethics well, you have to stop long enough to ask and answer the question, what's going on here? And I'll use that with, I'll describe that with the word to describe, okay? Describe is a kind of a weak word, but I want all words with D, so I had to choose describe. But it's how do you interpret the situation and describe it? Okay, this is what's going on. Well, Niebuhr said, okay, once you know what's going on, then you got to figure out, how do I respond to what's going on? I mean, remember, he was writing in the days in which psychology had been pretty much overcome by this notion of stimulus response.
Like Skinner?
The behavioralist psychology, that you stimulate a creature and they'll respond, almost like it's reflex. And Niebuhr was interested in making the response more than reflex. He wanted it to be responsible response. Responsible response has been, you've thought it through. And it asks the question, what is this is his magic word, what is the fitting response? That is to say, given this situation, how do I decide what response fits the situation? And that was where he was really, I'm not sure that you'd say, I don't want to say, I think I had to fill in a few blanks on Niebuhr here as to figure out what fits the situation. He was aiming that way, but I don't think that he did enough for me to say, oh yeah, he's got the whole thing figured out here. He's telling me exactly what fits. I think what he's telling me, that everybody's got to decide what fits for themselves, that he's not going to be able to tell you in advance. He was pretty clear that you do not know in advance what the response ought to be. You need to think that through and respond in a responsible way. For him, responsibility, you see, meant that had to be intention, that had been well rehearsed, that was coming out of all of your knowledge about what ought to be the outcome here, what is desirable for the outcome here. But he didn't, there's something about that little quickie, what's going on here and what's the fitting response to what's going on here. Something about that did not answer enough questions for me. And that's why, Paul, you're going to want to turn to that other section, that middle section. Nevertheless, okay, here's what I'm going to tell you about what's going on here. What's the fitting response? That matches medicine. Here's the diagnosis. Here's the treatment. Okay. And it's almost like, gee whiz, that's automatic. You got pneumonia, it's penicillin. No, you know, back in the old days anyway, you know. So, you know, here's the diagnosis. Here's the prescription. Medicine is not quite that easy. You don't just look it up in the book. You know, once you have strep throat, you just don't look up in the book what to do next. Doses, how frequent, whether it's the right one for this child at this time, who knows? A lot of things come into that magic word. Does it fit the situation?
Yeah, excellent. Thank you, Robert. And so just as I'm reflecting on what you're saying, again, Niebuhr's asking the question, what is going on here? And when you think about medical ethics, you come into a room, you've been asked to serve as a medical consultant to the doctor, to the nurse, to the social worker, to the family members, to ... a variety of people. And you have to hear from each one of them, what is going on here? And that fits for you as a personalist. It's not just the individual. It's not just you. It's not just one individual. It's a community of individuals. It's a community.
Exactly. We call it all of the stakeholders. Stakeholders are sort of a magic word in the ethics world. You got to listen to where everyone is coming from.
And last week you had said something, I believe it was during the interview. The second week is this week. The first week, last week, we were just dealing with what is personalist ethics in medicine. But I think you had said in medicine itself, there were in the past times, and often were times where the doctor would say, I make the decision. I will decide what happens with this patient. They weren't thinking of the community. They're not asking the question, what's going on here, hearing from others, what's going on here, what do I think's going on here? And that's determinative. And you're saying, no, there's a lot more involved. There are many stakeholders and we need to inquire of them. And that fits your sense of the communal aspect of personalism. And first and foremost would be the person who is sick. I mean, they're the ultimate stakeholder in this matter. And I know you'll talk about that. You've talked about that already in a previous episode. Now, then the question is the fitting response. And you said, now that is where it connects with medicine. What's the problem? What's the diagnosis? What do I prescribe, right? And while it's complex, those are important. However, and those are important, you know, it's first and second, but there's something between the first and second. So let's make first and third. What is that second question, the one that you insert between Niebuhr's questions?
You know, I guess I was trying to tell you that I was just a little bit less than fully satisfied with Niebuhr's description of how do you go about finding out what's fitting here. Mm-hmm. And the reason was that I felt like I kept asking, fits what? I was scanning some little book of essays by a crusty old philosopher. You know, you can read crusty old philosophers, occasionally get something good out of it. You know? Just scanning through a series of essays. And the title of one of them was, What Ought I to Care About? Bingo! That struck me so solid. When I'm dealing with a complex situation where there are multiple stakeholders, many people, many persons eager to figure out what to do here, what ought I to care about? And I said to myself, I ought to care about the person who is the patient. There's something that needs to focus what I care about, what I'm concerned about, what matters to me, what really makes sense to me, what ought to guide me into figuring out what fits here. So that central question, what ought I to care about, or what ought I to be concerned about, to me is so important. For me, it's actually, it's not that the other questions don't have their religious, theological, spiritual dimensions, but this is where it really focuses. What should I care about in this person, about them and their relationship to God, and the relationship to God that all that's going on here? And that's where my main mentor, James Gustafson, said all of our responses ought to be focused on what is the relationship of all this to God. And you know, I began to fill in that central section as being that which I have to zero in on and try to figure out what is the core value here that this person is interested in, and how does that value, that relationship relate to the relationship to God. And so the central question is not a little flippant, oh, what ought I care about here? Well, I ought to care about the fact that I'm late to the basketball game and I better hurry up and make a decision and get out of here. It's not that kind of what I ought to care about. It's really looking profoundly deep. This is where ethics has to pause. I called it, and when I was working, the moral pause. This is where you really ground yourself in who is this person? What is their relationship to God? What's going on here that is going to be informed by caring about caring? So,
oh, go ahead.
Now it doesn't give you an automatic answer, Paul, but it focuses the questions, focuses what you're going to care about, and begins to fill in what fits the situation. Because the last piece, I'm going to choose now to act in a way that will realize the main value that I ought to care about. That tells me something about what's the fitting response. The fitting response is that which realizes that which I ought to care about.
And I love this, you know, and I've interviewed you many times on a variety of subjects. You know, you're always passionate about each one, but I think this series, I'm just noting that what you care about, Robert, really comes through all the more in this discussion of medical ethics. Everything flows from it. These three questions are always the questions you're thinking about. And just as someone who has dialogued with you multiple and innumerable times really on these types of subjects, you know, it really speaks to me, and thinking through it in terms of just my daily dialogues in the medical community right now as we process things related to our son's care. Now, if you have the first question and the second question of Niebuhr, you might not ever think about the person.
Yeah. It's just, what's the diagnosis? Well, here's what we do with it.
Right. And I think it's hard. And by the way, before we go further, just for the record, the crusty old philosophy text, the author's name was, you mentioned him to me before, but for the viewer.
Harry Frankfurt.
Yep, Harry Frankfurt. So
Harry Frankfurt, yeah.
Yeah, what ought I to care about? And you know, I think it's hard for surgeons. I think it's so hard for doctors and nurses. I mean, it's painful at times dealing with patients. You know, you want to maintain the objectivity, because, you know, and that's right, to maintain the objectivity, but that's that middle question, the question you inserted by Frankfurt, especially when you frame it in personalist terms. Because you could say, what do I have to care about? I got to get to the basketball game, so I got to make a decision with this patient. Or, I got to think about the insurance costs or the cost of the.
Exactly.
Yeah, so there are all kinds of questions or values that get shaped, but your value as a personalist shapes that intermediate question in a unique way. You're saying the patient because you're a personalist. Non-personalists might not look at the patient, but your personalism comes in to shape that intermediate question. So I just know for a lot of doctors and nurses, and as I've engaged some, it's kind of like with police officers. At some point they see problems daily. It's very easy to detach. And the question you're asking them to keep before them is this person. That's hard. I can't imagine how hard that might be, because that middle question is an empathy question. Especially when you take it up in personal terms. You have to have the medical objectivity, the diagnosis of the problem, prescription of medicine. That's hard enough. It's not easy. You can't just look at a book. I get it. You can't go to Dr. Google. But in some ways, even more difficult is to keep those in place while bringing that intermediate question, because you're saying objectivity and empathy. Wow, that is a tall order. And I'm just observing back on what I've heard you say. Any thoughts before I go to the next question for you on this subject?
I think your rehearsal of it is so accurate. I just don't even. I'll just give you an A and ask to move on.
Okay, thanks. All right. So that said, and no doubt we'll come back to some of this and weaving it all together today and in future episodes. So just to review for our viewers and listeners, first question. This one comes from Niebuhr. What is going on here? The second question, which comes from Frankfurt, is what should I care about? Third question, back to Niebuhr, H. Richard, is what is the fitting response? Now, you've said you think that really reflects the kind of virtue ethical framework, by and large. And that may be true. Your mentor, James Gustafson, feels the same way, or felt the same way, I should say, about this matter. We're not going to get too much into this, but it's not like you have a prescription model. You look in the medical book or the medical ethics book, and it tells you in this situation, 1, 2, 3, 4, okay, plug it in. It's more complex than that. You don't have a definitive answer at every point. It's not the greatest amount of pleasure for the greatest number of people, certain kind of utilitarian ethics. It's not deontological ethics with Kant, a prescription-based, maxim-based approach, as he's often understood to present his kind of personalism. It's much more a matter of what kind of healthcare provider are you, is what I think this is about, which fits more of what might be called virtue ethics. The good caregiver, the virtuous caregiver. And for you, as I see it, a virtuous caregiver is accounting for what is going on here, what should I care about, what is the fitting response. And so feel free to come back on that, but let's consider a concrete example. What is one scenario where you've applied these questions in order during your medical ethical practice over the years, including your teaching at Oregon Health and Science University in that domain? And how did these questions in that case study situation help you navigate that situation in more or less satisfactory terms? And I say more or less because I'm sure there are times, as you've told me before, you wonder, did I make the right determination here? There's always a risk factor because you're dealing with people, and people are mysteries. So thoughts on this, Robert, please. Dr. Potter.
When I came back from my PhD study in mid-professional life, I fell into the need to be medical director in 4 very busy nursing homes in my Kansas City, Kansas, where I was practicing. And the deal is this: the physicians in that area would never go to the nursing homes. So those patients, which amounted to about 600, were my patients while they're there. I was the one making the decisions. Well, I remember the case of Sharon. Sharon was a 35-year-old woman in a very advanced stage of what's called Huntington's chorea. That's a neurological degenerative disease that affects motor muscles, so that there's paralysis in the limbs, there is difficulty swallowing, difficulty in speech, the muscles of the throat atrophy. There is not much in the way of deterioration of mental capacity. In fact, that usually is retained to the end, which makes it so tragic, because a person knows that they are withering away and they see it in themselves, and so are those around them. Well, Sharon was at a pretty advanced stage. In fact, she was so advanced, she could not eat successfully. Because her muscles in the throat were paralyzed, when she ate, much of the foodstuffs would go into the lungs rather than go on down into the stomach. So she would soil her lungs and get repeated episodes of pneumonia. Okay. She made arrangements. She had 2 children, all of them grade school children at this point, still, well, high grade school, that 10 and 13, I think. And she had a father for those children who was no longer her husband, but had been given a court appointed as caregiver for the 2 children. And she had made out an advance directive that said, I do not want to be artificially fed if I get to the place in which I cannot feed myself or cannot eat successfully. Okay, that was her personal decision as a person, and everybody in the nursing home understood that. She had not been able to write out an advance directive, but a social worker and another person who acted as her durable power of attorney and so on was able to make that official so that it was valid. The only problem was her mother didn't agree with all of this. And her mother, on one occasion, took Sharon out of the facility to a nearby medical school, which happened to be at that time Kansas University School of Medicine, and was seen there by a neurologist and persuaded the neurologist to insert a gastric feeding tube. That's a tube that's rather bypasses the mouth and throat and esophagus, goes directly into the stomach, because she wanted her daughter fed. She felt like that was what she owed the daughter as a person. So she had her perspective. So Sharon comes back to the nursing home now after 2 days in the hospital with a gastric feeding tube. She is so angry that she becomes mute. She won't talk to anybody, me included. The nursing staff is in a great deal of distress. We called it, we even invented a word during the late 1980s. We called it moral distress among the nurses. Moral distress, when they are forced to do that which they know the patient does not want done. And they were in deep moral distress because they saw the person, Sharon, had not been honored, but had been taken to the medical school. Some physician had been persuaded by the mother, acting on what they thought was good for the patient. And now we're in a situation where the person, Sharon, has been ignored. And here I am, not quite sure what I'm going to do with this. The gastric feeding tube is not so invasive. It's not uncomfortable. And it does give Sharon nourishment. And I was just sort of sitting back and kind of waiting to see if the situation would work itself out, Paul. I wasn't sure exactly what I ought to do in this situation or what would be the fitting response in this situation. I was still kind of processing it, pretty much disturbed by the fact that she'd gone to the medical school and the medical school had ignored the advanced directives and put in the tube, but didn't even know whether the advanced directive had been taken to the hospital so that anybody there knew that it existed. So I hadn't yet figured out the total of the situation of what's going on here. Well, the nurses were pretty ambitious, let's say, about pushing me into making a decision. Well, let me ask you, Paul, what do you think the fitting response is? Sharon is being fed. Her life is preserved. That's a good thing. The feeding is not uncomfortable to her. It can provide full nutrition. I've had many patients live years on the gastric feeding tube. We're not harming her, are we? We've avoided that old dictum, first do no harm. Doesn't it fit? Here's a loving mother who wants her daughter to stay alive. So tell me, Professor, what's the fitting response for the old doc here?
Well, I will give you my thoughts. I just have to articulate how I'm processing my decision, because I'm trying to account for the three questions. What's going on here? You've accounted for the idea, what Sharon herself wants. What her mother wants is not what Sharon had articulated, and I'm assuming her mother knew what Sharon had said. And I know with grown children or children that are, beyond a certain age, one of the things they most want their parents to do in relationship is to honor their autonomy or their agency or their personhood.
Yeah.
And so my children would feel I'm violating them as adults if I did not account for their views on matters first and foremost, so on and so forth. So that's just from a relational vantage point. How I have experienced relationships with my own children, and also I think what I know of others. And Sharon was angered by what her mother did in convincing someone who had not even been part of that dynamic, someone completely out of the system, taking her out to make that determination, did not honor, without meaning any disrespect toward her mother, that whole nexus of relationships that were more immediately engaged, shall I say. So I would want to honor Sharon. Now, I appreciate what you did, not just because we're friends, but sometimes you need more time to process because there was a wrinkle, shall we say a major wrinkle, thrown into the system, a wrench thrown in. And it's like, will this take care of itself? Will there be something that happens in the condition? It's not like great evil is happening in her physical condition. But, and then we have to account for the fact that medicine, it's not just what we can do, but what ought we to do, because medicine can do a lot of things.
Yeah.
Today that it couldn't have done 200 years ago. So it does much good, but it complicates things more. So just because we can do it, we have to ask still, because it's the ethical question, not can we, but should we? And so I would be inclined somehow or another, however that plays out medically, to honor what Sharon wanted and wants, whether or not I agree with her and agree more with her mother, on just on a given subject, because this is what happens with families. I had a relative who the husband wanted this person to allow him to pass. Another family member did not like it and fought it. And this relative said, but we need to honor, I'm going to call him Bob. His name's not Bob, but we need to honor what Bob wanted. Caused major tension. But this relative was trying to honor the person who I call Bob. So that said, that's how I would proceed, but I don't know what that looks like medically in terms of removing the feeding tube, unless Sharon said, you know what, my mom's right. If she could somehow communicate in writing or something, my mom's right, I was wrong. I account for that.
Yeah,
but I don't think
I even thought about the possibility, Paul, that once the tube is in there and Sharon feels a little flourishing from getting some nourishment, maybe she would say, well, it's not so bad. I'll take this for a while. I'll stay alive a little while longer. She may have shifted her own value system. She may have decided what really matters to me is I'd like to stay alive a little longer, see my kids grow up a few more months, maybe a year, who knows? I kept saying to myself, will this change of the situation change the situation? Change the response to the situation? It complicated my life, seriously.
Heavy stuff, very sobering. It's far more complex than, should I go to the basketball game, and what time should I get there? A lot more complex. And I'm sorry for Sharon and everyone.
Okay, let me bring it to a close.
Yeah.
Obviously, what fits the situation may not be an absolute. There may be more than one way to fit the situation. On the other hand, to decide is to cut off all other possibilities. If I leave the tube in, I can't take the tube out. Oh, yes, I can eventually take it out. There's no law that says I can't stop feeding once I've started feeding. Some people think that there's a law about that. There is none. But once you make a decision, you've cut off other decisions. That's the meaning of the word decide. It comes from the Latin. It means to cut off. To decide is to cut off one possibility, and the rest of the possibilities are not. But you could shift from one to another. Yeah. So what I did is that I got everybody together that was involved, including the mother. She objected, but I overrode her objections and stopped the feeding. It took nearly 2 weeks for Sharon to die, but we saw to it, using the best palliative principles that we could, see to it that she was as comfortable as we could possibly make her. She stopped being mute after 4 or 5 days, if I recall, and was able to feebly thank us all for allowing her death to occur. But that's a tough one. But I used the 3 principles: describe the situation, discern the value, decide the response. Describe, discern, decide. Those are my 3 Ds that I try to use in teaching so that people can remember a little bit more, Describe and discern and decide. Knowing that you may have to redecide. I was even prepared, Paul, that if Sharon would wake up and say, I want the tube back, that I would put the tube back in again. See, the fitting response needs to be constantly re-evaluated so that it in fact fits the situation, because the situation may be fluid enough that it's changing too. So the three strategies, the 3 pieces here, you have to be willing to redo each of them. Maybe down the line, some new information about the situation would come up. I won't even tell you about the money involved in the whole story, but because that was another wrinkle in the situation. You know, money from an insurance policy that was going to be questionable if we allowed her to die. Yeah, but you know, the complexities are just keep building up and building up. So that's why you have to keep making each of your pieces of the decision-making process, keep them fluid, keep reevaluating. That's why we say you always do ethics critically, always willing to critically assess what you have decided, continue to re-describe, rediscern, and redecide.
And I think that's so helpful because people's lives are narratives. People's lives are stories. So there is a past, there's a present, and there's a future. And for example, in Sharon's situation, she might have had a rethink, and you're accounting for it. You wouldn't say to Sharon, you know, I just know you, but you know, based on what you've just said, sorry, Sharon, this is what you told me 2 weeks ago. And even though you want the feeding to, nope, you told me 2 weeks ago. No, it's the matter of people are growing, people are developing, and people make determinations thinking one state of affairs. And then once they're in a new state of affairs, they may rethink. And again, to me, this is not relativism. I think some of our viewers, listeners might think this is relativistic. I think it's personalistic. It's accounting for narratives, it's accounting for stories, and it's embeddedness in communities. And it is accounting for.
But it is relative to the extent that the person, where the person is relative to where they are in their story.
Yeah, exactly.
And their story changes.
Yeah, and of course you're accounting at every turn for the relationship with God and for scripture and truth and all of that. That's all part of ethics, but it's not a static reality. It's dynamic, and I think we have to account for people as storied beings. So as we close, what recommendations would you make to viewers and listeners if they seek to apply your ethical framework, which is really an approach and method rather than a set of prescriptions and propositions? And I'm just going to say one thing and then leave it to you to say what you need to say in answering this question. But I know you would say, make sure you account for appropriate amount of time. Don't be hasty. And a lot of times on these major life-changing questions, you have said that people are often premature to come to decisions. And don't be hasty. Robert, your thoughts. Dr. Potter, your thoughts.
Absolutely. I call it the moral pause. And the pause may be quite a long pause. It may not be just a few minutes to think about it, or a few days to think about it. It may be months. It may take a long time to reach a decision that you feel like you can responsibly make. Remember, what Niebuhr was trying to understand was just how powerful the word response is. He does not want us to react. He does not want us to do it by reflex. We want to respond is a deep working through of what's going on here. What ought I to care about and what fits the situation? Amen.
Amen. And as we close, Robert, I just want to say something that came to my mind just now. When Niebuhr was engaged in this, again, the context was behavioralism, it was Skinner's work, it was response to stimuli, could be really involuntary in many ways. And he was talking about being responsible means to be voluntary, to be thinking through. And I think if medicine's not careful, if we don't have a personalist approach to medicine, even today in the 21st century, we can fall back to that behavioralist orientation. And I think what can happen is that people can make determinations in the medical community that are more behavioralist in orientation and almost operate in ethical decisions in an involuntary manner.
And leave the person and leaving the person out.
And leaving the person out, and even making decisions, they think they're accounting for the person, which doesn't account for they themselves being voluntary. Oh, it's just inevitable. And I had a friend who was told when her father was on life support, just get on with it, pull the plug. And she had just come out of, she had to travel to see her dad. She was the closest family member. Pull the plug. What are you waiting for? Well, she didn't. She said, I need time. And, he responded. He came back and lived for several years. Now, that doesn't always happen, but the point was, she was asked almost to be involuntary. And she said, I need to be responsible. I need to think this through and make discerning decisions and have the moral pause, your language, but that was what she was doing. Dr. Potter, thank you so much. Next time, we're going to be engaging a personalist approach to medical ethics, objectivity, and empathy. How do those go together? And that has merit even beyond medical ethics. We all need to be objective and realistic. And part of that ethically involves empathy too. That's part of that whole moral matrix and scientific matrix and personalist matrix, objectivity, that kind of realism, but also the reality of the person and empathy. Dr. Potter, thank you so much. Viewers and listeners, thank you so much. Paul Louis Metzger signing off as we discuss personalist approach to medical ethics, 3 cardinal questions. Blessings to you as you hit that moral pause button to think through these issues with us. Blessings to you. Good night.